Hello, I am Dr. Ruben Nieswisky, and I'm the Director of Multiple Myeloma Center at New York Presbyterian Hospital, Weill Cornell Medical Center. Welcome to this case-based e-learning activity. That is a case 2 in a series of 3. I will be discussing with you today a case of multiple myeloma and sharing some key data and insights, and I hope that it will help provide you outstanding clinical care to your patients. Let's start with the case. This is Mr. C, a 68-year-old male who presented 10 years ago for blood work during a neurologic evaluation for peripheral neuropathy. He was found to have monoclonal protein and Bence-Jones proteinuria. His past medical history was relevant for an atrial fibrillation, which was diagnosed 4 years before, which has been uncomplicated. Also has a history of abdominal aortic aneurysm, which is small and uncomplicated. No former toxic habits or smoker, and no family history of relatives. In his initial laboratory examination, it was clear that the patient had serum immunofixation positive for a monoclonal lambda protein, and further testing showed a serum beta-2 microglobulin of 3.1, and his immunoglobulins were suppressed with an IgG of 460, IgA of 41, and IgM of 60. The 24-hour urine revealed a total protein of 1 gram in 24-hour urine immunofixation positive for lambda, and a urine protein electrophoresis of 20% albumin with an 80% M protein. You can see in the next slide the serum protein electrophoresis and the serum immunofixation, which shows clear the presence of a band in the lambda region. No M protein was actually detected. The next slide shows the urine, which is dated December 23 of 2013, which is also clear for a monoclonal protein in the gamma region in the panel of the left, with a clear lambda band in the panel on the right, conclusive of monoclonal free lambda light chains in the urine. The skeletal survey was normal, and in the next slide you can see the initial PET scan evaluation, which shows no distinct focal increased uptake or elevation of any FDG uptake in the organs or viscera. The axial and the appendicular skeleton was clear. The bone marrow biopsy revealed clonal plasma cells population, lambda light chain restricted, both CD38 positive and CD56 positive, with a total of 30% plasma cytosis, consistent with a plasma cell neoplasm. The next slide shows the infiltration of these plasma cells in an H&E, normal cellular marrow, with normal elements, except for the presence of these mononuclear cells with eccentric nuclei and negative Golgi. The next slide shows the CD138, which identifies the plasma cells infiltrating the bone marrow. And you can see in the following slides that these cells are cyclin D1 positive. And in the last morphological side, you can see that the co-staining of MUM1 and Ki67 shows a low proliferation rate. In the next slide, you can see the evolution of the patient as how the free light chain lambda levels change through the time. And you can see in the last year or so how the levels have changed between a level of 90 to 80 to even as high as to 50 and back to a level of 150 to 160. So the questions that this case brings is the following. The treatment for this patient is indicated because the patient has depression of the uninvolved immunoglobulins, or because the patient has a risk of AL amyloidosis, because he has light chain disease alone, or because the patient has bone marrow plasmacytosis that is beyond what is accepted, because of the phenotype of the plasma cells, or the patient should not be treated at all. So we'll try to review what is the data that would answer these questions. To review these questions, we would like to take consideration the following points. To decide whether the patient will require therapy, we will pay attention to the M protein level, the bone marrow plasmacytosis and aberrant expression of the plasma cells, the evolution of the disease, the presence or absence of light chains, are there any cytogenetic or FISH abnormalities? Is the unevolved immunoglobulin information important, or the presence of MRI abnormalities also important? So let's start talking a little bit about the M protein level. With this, the question I have is, in regard to the M protein, the following factors render higher risk of progression from smoldering to active myeloma. And then we have the options of M protein of 4 grams or more. The second is IgA M protein. Light chain only is number 3. And the fourth is any level. The answer for this question is an M protein of 4 or more. And this is based on the data that has been published by Kyle and co-workers in 2007 in the New England Journal of Medicine, in which several factors were evaluated to define what patients with smoldering myeloma have high risk of progression. Indeed, patients who have a serum monoclonal protein of more than 4 grams per deciliter had a median time to progression of 18 months, compared with the ones who had a lesser level of M protein, which had a median time to progression of 75 months. So let's talk a little bit about bone marrow plasmacytosis and aberrant expression of the M protein. In the same paper, Dr. Kyle reviews patients who have bone marrow plasmacytosis of less than 20%, 20 to 50%, or more than 50%. And as you can see, people who have less than 20% bone marrow plasma cells have a median time to progression to active myeloma of 117 months, whereas patients who have a bone marrow plasmacytosis of more than 50%, the time to progression is quite short of 21 months, this being statistically significant. More important, you can see in a more recent evaluation that patients with smoldering myeloma who have a bone marrow plasmacytosis of more than 60%, 80% of those will have progressed by 2 years. In other words, people who have a bone marrow plasmacytosis that exceeds 60% will have active myeloma by 2 to 4 years. This group of patients have now been identified as ultra-high-risk patients, and the school of thought is to initiate therapy early on these patients. But what about the aberrant expression of antigens in these on plasma cells? The Spanish group has already identified people who have normal plasma cell phenotype depending on the C38 expression. And based on that, one can identify people with a MGUS phenotype, whereas people who have a more active phenotype will have more chances of progression. For the MGUS, the median time to progression is about 107 months versus non-reach for patients with 95% or greater versus less than 95% aberrant expression. For smoldering myeloma, the median time to progression was 34 months and not reached for patients who had the abnormal aberrant expression. And therefore, it's important to categorize the plasma cells of these patients to define progression. So the typical aberrant expression are manifested in this slide, in which CD56 is positive, CD19 is negative. And that happens in about 50% of the patients. 24% of the patients will have 45, 19, and 56 negative, also as part of the aberrant expression of abnormal plasma cells. The other combinations you can see are less common. So the question I have for you now is the following. Plasma cells with aberrant expression and higher risk of progression from smoldering to active myeloma include the following, except CD56, CD45, and CD19 positive. Number 3 is CD38 positive. And the last is CD45 negative, CD56 negative, and CD19 negative. The response is all the options except number 2 are typical of abnormal plasma cells because CD45 positive and CD19 positive are characteristic of normal appearing plasma cells, and therefore these are not aberrant expression, and therefore do not detect plasma cells in patients who have a higher risk of progression into active myeloma. In this case, you can see how time to progression from active myeloma to MGUS also depends on its proliferation and its expression and abnormal phenotype. If you have an MGUS-like profile, as in the panel in the left, the chances of progression are very low, with a median of 243 months. But if you have a multiple myeloma-like profile in patients with progenitor disease, such as MGUS of smoldering, the median is much shorter for progression. So the next question will review what we have just reviewed, and that the following is true in regard for clonal bone marrow plasmacytosis of 60% or more. Number one, same risk of progression of a patient who has 30% plasma cells. Number two would be 80% of patients who will likely progress in 2 years. Three is these patients often have renal failure. And number four, this phenotype always heralds AL amyloidosis. The answer is number two. 80% of the patients will likely progress within 2 years, and that's why we call these patients ultra-high risk progression. And school of thought is that these patients should be treated early. What about the evolution? Indeed, as you can see, the patients with smoldering myeloma, contrary to the patients of MGUS, there is a higher frequency of progression during the first 5 years, and then the smoldering myeloma, which is the curve in the top, tends to flatten out and plateau with lesser risk of progression, whereas patients with MGUS tend to have a linear, more progressive frequency of progression as the years pass by. But if you look clearly, patients that progress with smoldering, most of them progress within the first 5 years with a 10% of progression rate, whereas between the 5th and the 10th year, you will see a lesser progression to 3%, and in the following decade or so, the risk of progression is 1%. So somebody has to evaluate patients with smoldering myeloma early and see that the progression rate during the first 5 years is indeed higher, probably because we're detecting patients who were already with active myeloma, however, those patients were myeloma in evolution. So a very important part of the history is for how long the patient has been having the parameters of smoldering myeloma in trying to predict progression. So to review this concept, we have to answer this question. The risk of progression from smoldering myeloma to active myeloma is, number one, 1% per year. Two, is linear, just like other precursor disorders such as MGUS. Number three, progression risk is higher the first 5 years after diagnosis. And number four, patients should be treated early since it's more likely to progress the longer you wait. The right answer for this question is number three. As we just reviewed, progression risk is higher the first 5 years, and that's why those patients who progress are patients with myeloma in evolution. The longer you wait with patients on smoldering myeloma without progression, the less likely these patients will progress, which is contrary to MGUS, which will have 1% progression per year, is more linear, and it is a lesser frequency of progression with lesser time. What about the light chains? Well, if you just look at light chains as predictors, you will see that patients who have a free light chain ratio of more than 1/8 or less than 8 will have a lower risk of progression than those who have a higher level of free light chain ratio. This has been published by the Mayo Group. And more clearly now, when you look at patients who have a ratio of more than 100 to less than 100, because the median time to progression of patients who have a free light chain ratio of more than 100 will have progression in 15 months, median time to progression, whereas those who don't have a free light chain ratio of 100 will have a much longer time to progression. So it is expected that patients with a free light chain ratio of more than 100 will have progressive myeloma in a rate of 70 to 80% by 24 months or so. Therefore, these patients will also be called ultra-high risk and probably will require therapy as well. The question for this section is the following. The following is true in regard to light chains in serum in smoldering myeloma, except light chain smoldering carries risk for renal disease. Number two, a ratio of 100 identifies patients with approximately 70% risk of progression to active myeloma. 3, lambda is more frequent than kappa. And 4, AL amyloid and poems often have lambda phenotype. So the wrong answer here is number 3, lambda is more frequent than kappa, because light chain smoldering carries a high risk for renal disease. Number 2 is also true, as the ratio of 100 identified patients with ultra-high risk smoldering with a 70% risk of progression to active myeloma. And number 4, AL amyloid and poems are often lambda phenotype. When you look at the data putting together plasma cell infiltration, the serum M protein, and the free light ratio, you can combine all these 3 factors and establish a model of progression, indicating that people who have the worst outcome are those patients who carry the 3 risk factors: a free light chain abnormality, higher serum M protein, and a plasma cell infiltration, putting together all what has been published by Dr. Kyle and co-workers. With the advent of cytogenetics and FISH, one wonders whether that can also be predictive. And very few cohorts have been identified to answer this question. However, it comes to mind that this study by the German group, in which the gain of 1q, the deletion of 17p13, or the translocation 414, and deployed status at the time of progression, was evaluated to identify high risk versus low risk. And here you can identify patients with high risk in all the groups, suggesting that indeed gain of 1q, the presence of deletion 17p13, or the translocation 414 do select patients that would progress early, even in the smoldering state. What about the uninvolved immunoglobulins? Well, in the original classic study of Kyle and co-workers, you can see that if you have 2 immunoglobulins depressed, have a likelihood of progression of 32 months, whereas people who don't have depression of the uninvolved immunoglobulins have a very long time to progression of 159 months. Therefore, suggesting that it's another factor to take into account when we are evaluating patients for progression from smoldering to active. And indeed, the Spanish model incorporates depression of the uninvolved immunoglobulins, or what they call immunoparesis, in combination with the aberrant expression of antigens in the plasma cells. And they put it together in 3 different groups in this model, showing that those patients who have no adverse factor have a very low risk of progression, whereas people who have both the aberrant expression of antigens in the plasma cells and immunoparesis offers the highest risk of progression at 50 months or 60 months, etc. Finally, I would like to talk a little bit about more sophisticated radiological evaluations, such as the MRI. And although the information available is scanty, there is this letter to the editor by the Greek group, in which shows that the presence of focal lesions in the MRI do predict early progression in patients with smoldering disease. So why is all this important? In the past, none of the interventions that we could do with bisphosphonates or early chemotherapy really had any impact in the therapy of myeloma. As you can see in this panel, initial treatment with conventional agents such as methylprednisolone or diflunomethylprednisolone had no benefit in overall response rate, time to progression, or overall survival. With the immunomodulating drugs and other novel agents, for instance, with thalidomide, there was a high toxicity which precluded any benefit in the overall survival. And the bisphosphonates, although showed no benefit in overall response rate, time to progression, or overall survival, there was a lower incidence of skeletal-related events. So all this changed when Dr. Maridib Mateos from the Salamanca group brought to light this study, which was published in the New England Journal of Medicine, in which they compared the use of lenalidomide and dexamethasone versus therapeutic abstention or observation in smoldering patients with high risk, using principally the model on the Spanish depression immunoglobulins and the aberrant expression of the plasma cells in identifying patients with high risk. And in this study, 60 patients were randomly assigned to receive lenalidomide and dexamethasone, whereas the control arm received no therapy whatsoever in the induction phase. And in the maintenance phase, after 9 4-week cycles of induction, patients on the therapeutic arm received lenalidomide maintenance versus observation, or what it was called the therapeutic abstention. As you can see in the following slide, by intention to treat analysis, lenalidomide and dexamethasone proved to achieve a much longer time to progression to active disease. And what was more important in the following slide, there was an overall survival advantage for the use of the immunomodulator plus dexamethasone versus not treatment. So this approach, although needs to be confirmed, has been suggested to be one option for those patients with high-risk smoldering myeloma. We must notice that there are some critiques. The arms were not completely well balanced. There was a higher mortality in the control arm because there was an intervention only when the patients developed hypercalcemia, renal disease, anemia, or bone disease. And those patients who had biological progression, from asymptomatic progression, they had the option to increase the dose of dexamethasone in the intervention arm. And therefore, there was some suggestion of imbalance in the arms. And again, not everybody could do flow cytometry except in the model that Salamanca has, which is one of the best places to have flow cytometry evaluation. However, the International Myeloma Working Group has adopted evidence that I just presented in the ultra-high risk to shift the diagnosis of multiple myeloma, even in those patients without active disease, as manifested by hypercalcemia, renal insufficiency, anemia, or bone disease. And in this paper published in Lancet Oncology, you can see that now the presence of clonal bone marrow plasmacytosis of more than 60%, or the presence of free light chain ratio of more than 100, and the presence of an MRI with more than one focal lesion is now being used to define active myeloma, and therefore these patients should be indeed treated. So in an attempt to answer the initial question, going back to our patient, treatment for this patient is indicated because, yes, the patient had depression of the uninvolved immunoglobulins. Yes, the patient had light chain disease. The patient had a bone marrow plasmacytosis of 30%, and the phenotype of these plasma cells were indeed aberrant. However, this patient actually refused to be treated, and the patient has not progressed, which is a question that we always entertain with certain patients. This particular patient is interesting because even though we have offered therapy based on the data available, the patient remains on observation without evidence of progression. In order to review the data we just presented, I have designed this algorithm based on what we have shown, and tries to summarize the findings which were highlighted in this myeloma patient. So when considering a patient with smoldering myeloma, we have no evidence of end organ damage by absence of hypercalcemia, renal insufficiency, anemia, or bone disease, but have a bone marrow plasmacytosis of more than 10% and an M protein of more than 3 grams, which is a typical patient with smoldering. One will first look at the bone marrow plasmacytosis. And if the bone marrow plasmacytosis is indeed less than 10%, the patient will still be considered monoclonal gammopathy of undetermined significance, and the patient will be just observed. If the bone marrow plasmacytosis is more than 60%, then immediately the patient should be considered as active myeloma, and given the high risk of progression in 2 years, the patient should begin therapy and is now considered active disease. In terms of the free light chain, if the difference between involved and uninvolved free light chain exceeds 100, then the patient also will be considered active myeloma, given the very high risk of progression in 2 years. And these patients are particularly in risk of developing renal disease, and therefore the International Myeloma Working Group has considered this now active myeloma. If the patient has more than one focal lesion by MRI, it's also considered very high risk for progression, and therefore these patients should be treated there. If none of these patients have these characteristics, then the patient will remain on smoldering myeloma and will be observed or encouraged to participate in clinical trials. It still remains to be defined what is the contribution of fish as the predictor for progression, but there is some data that suggests that these patients will also be at high risk of progression. With this, I think we can summarize the newer approach for patients with smoldering myeloma. Indeed, it's been a pleasure presenting this case, and thank you for participating in this activity with multiple myeloma. I hope this will enrich your practice. And I also invite you to participate in the other 2 cases with Dr. Myron Chuchman presenting mantle cell lymphoma and on myelodysplastic syndrome presented by Dr. Raul Kibes. Thank you very much.